Hello, everyone. I'm Rose Gerber. Thank you so much for all of you that are extremely punctual and may even caught a little tidbit of some of our pre-going live on Facebook portion. I'm so happy that you're here with us today, and I want to begin by wishing you all a Happy New Year. I hope you had a wonderful holiday season and a Merry Christmas. In December, we did something a little bit different with our advocacy chats. Normally, when we do our advocacy chat, it's a once a month, 30-minute event. And we always have a great time with them. At the beginning of the month, our special guest was Dr. Kashyap Patel, and we discussed his new book, which is called Between Life and Death. And it was a really great conversation. You can still find the video on our YouTube channel or on our Facebook page. And I hope that what you took away from that conversation was a better understanding of what the patient experience is like when you are living at the end of your life, and also how much value it means to a patient when you have a compassionate, caring team. And then we thought we wouldn't see you until today, but we decided that we wanted to bring you all of our participants back together at the end of December. And we took it very seriously because it was literally days before we were all going to break for the holidays. But there was a very important, very concerning issue taking place that had gone into, that was announced in late November by the current administration. And that was an issue that was potentially being put into motion that was going to threaten cancer patients, their access to care. And that was an experiment called the Most Favored Nation model. So we brought together our experts who are practicing medical oncologists. That was Dr. Deborah Patt from Texas Oncology. And we also brought Dr. Lucia Gordon from Florida Cancer Specialists. And again, even though those were two doctors, they represent many of our community oncologists all across the country. And we also had our executive director, Ted Okon, join us. And the purpose of that chat was to help all of us that aren't doctors and are not policy experts understand what is something called the Most Favored Nation drug model. What it sounds good, it seems like it's going to lower drug prices, help us make sense of it. And the three of them combined did a really great job with that. So I want to thank them again. And today our special guest is Ted, as you can see for those of you who see the title of our topic today is Coa's Crystal Ball. So Ted's going to begin by giving us some updates on what has happened with this potential experiment. So that's going to be very interesting. And also Ted is going to tell us what kind of changes we can all expect as either cancer patients and survivors, as care providers, when the new Biden administration takes the helm next week. So that's going to be very interesting. And as you know, Ted has spent decades physically being on Capitol Hill. In the last year with COVID, that didn't change. What changed is he was not on Capitol Hill physically, but he was still having one-to-one meetings. So we're going to get his insight and, more importantly, his intel, because we know information is power, and those decades of building relationships are proving very valuable. And also through this process, Ted is going to help us understand how, as our leader, what his vision is, what the COA board's vision is, and how that's going to work out with our advocacy and policy priorities for 2021. So I'm going to turn it over to Ted, and Ted, tell us what's ahead in the COA Crystal Ball. And again, thank you all for the participants being here. And a quick little special thank you to Steve Smith and Ann Slam, who let us know that we were live, and all of you that are participating today. Thank you. Ted, go ahead.
Great. Thank you, Rose, and thanks for having me. So the first thing I'm going to do is I'm not going to get in the weeds in this, because the legal weeds, which I have been living with our attorneys for the last literally 4 or 5 weeks, are pretty oppressive. You don't want to hear that, but what you probably want to hear is, where is this most favored nation, as Rose referred to it as an experiment. And basically where it is, it's halted in its tracks. There were 4 lawsuits, one that was filed in Maryland, principally by Pharma and some others, but Pharma had the lead on it, the organization Pharma. There was one by the organization Bio in California. Regeneron, a single company, filed a lawsuit in New York court, and we, COA, filed a lawsuit in the DC District Court. And the bottom line is that the Maryland court acted first and issued a temporary restraining order, meaning the administration was not able to implement this model on January 1st. And then the California court acted by issuing a preliminary injunction, which meant that the government would be enjoined or stopped from implementing this at all until down the road, or there was another hearing, or the government acted differently. So, or which included possibly appealing it. We received word on Friday from the government, because the government was ordered by our Judge Sullivan in the DC District Court, that if the government intended to appeal the California ruling, we had to know, the court had to know immediately, or if the government intended to go ahead with what is proper rulemaking and notice. And sorry for the wonky terms, but all it means is that the government, when it puts out things like this, is required to get the input of stakeholders, let them think about it, give them 60 days to comment, and then the government has to come back with reactions to those comments. So right now it's kind of dead in the water. And I think with last week's horrific events in DC, I think it will probably stay dead in the water, and it will be up to the Biden administration to look at this. There may be some additional court action on some other aspects of what the Trump administration tried to do. And that is, they tried to use what is referred to as CMMI, or the Innovation Center of Medicare and Medicaid, to basically use that in a wrongful way to, in essence, end run the Congress and change laws related to reimbursement or anything else. And that may get challenged still in the courts. So frankly, it will be the Biden's administration to deal with this. Of course, the inauguration is on the 20th, and go forward from this. But you know, I want to make two comments about this, and that's going to go into my next topic, to sort of dust off the crystal ball and tell you what I think may happen with the Biden administration specifically. And that is the fact that I've had a lot of people, I've had people on Twitter, I've had people call me, I've had people email me and say, hey, what's wrong with the fact of trying to reduce drug prices? Because we in the United States pay so much more than other countries. And I have two responses to that. First of all, and most importantly, which is why COA filed a lawsuit on our own, is that the way the government was going to do this essentially held providers and their patients as hostages, and to force drug companies to lower drug prices. And as a result of that, we felt that when you put something in motion that it's been analyzed is only going to lower drug out-of-pocket costs for less than 1% of Medicare seniors. But by year 3 of this program, CMS's own estimates is that 1 in 5 seniors would forego treatment. Imagine that. Think about that for a minute. They would forego treatment for cancer, other serious diseases that are treated by injectable drugs. And so I've never, in my 20 years plus of doing this, I've never seen the government try to do something that was going to positively impact so few patients, but going to have such an adverse impact on not just Medicare patients in that analysis, but other patients that are covered by commercial insurance. So that's why the COA board voted unanimously to proceed with a lawsuit. And we're still in the middle of this. We never want this to happen again. Now, with that said, let's look forward. What's going to happen? Right now, the Biden administration has one top priority, and that is to get a handle on COVID-19 and the vaccination. This vaccination rollout at both the federal and most state levels, interesting enough, the state that Rose and I live in, Connecticut, has actually done a good job, which is amazing because Connecticut usually screws things up. But basically, this has been a disaster, and we are working right now. We had a board call on Monday night with COA, and we are working. Practices are frustrated because they want to vaccinate their patients. They have the freezer, in most cases, they have the freezer capacity to do that. They certainly have the professionals to administer vaccines, and they're not getting those allotted. So You have hospital systems that are overrun with COVID-19 that can't administer vaccines, that these vaccines may actually go bad. So this is a disastrous situation. And regardless of how the current Trump and outgoing Trump administration has left things, the Biden administration is going to be very much judged on their response and what they do in terms of righting the ship, not just at the federal level, but at the state level. And that's tough because 50 states are very, very different. So as a result of that, that's their top priority. Now, you know that especially because you hear it from a lot of Democrats, and Democrats tried to push through a drug pricing bill last year, which they did get through the House, but then it died and didn't go anywhere in the Senate, is drug pricing will be a top issue. And anytime drug pricing comes up, it ends up involving literally reimbursement issues and issues that impact not only practices, but their patients. So we're going to be very mindful and careful of that. But here's the dynamic that's going on here. Essentially, if you think about it, the Biden administration has about 20 months to do something. 20 months. Why do I say that? Because once you get past sort of 20 months, 19, 20 months, you're into election season. And that's going to be a big deal because usually during the midterm of a presidency, a lot of times that Congress flips. And as you know, the House has a very narrow margin in terms of being Democratic. The Senate is split 50-50, but the tiebreaker goes to the White House, to the vice president, and proceeds as president of the Senate, and that will essentially be the equivalent of a majority, but a very slim majority in both bodies. So as a result of that, they have to get through COVID. How long is that going to take? And then you've got this clock ticking right now, about 20 months, and the clock is ticking. So you don't have a lot of time legislatively. So I think you're going to see a big push on drug pricing. It is not going to be that easy to get through, even though the Democrats control the House and the Senate and the White House, because number one, they have a slim majority in the House, and there are going to be Democrats that are in what we refer to as purple districts, both Republican and Democratic split, that are going to be concerned about keeping their seats. In addition, in the Senate, you have some very moderate senators, especially Senator Menendez from New Jersey in the middle of the pharmaceutical industry, who has basically stopped votes on things that are negative on the pharmaceutical side. So I think you're gonna see a very interesting dynamic of needing to get COVID done, and then next tackling drug prices. And I think you're going to see a lot of things on drug prices. I think you're going to try to see a reduction in what's referred to as Part D of Medicare, the oral side of what patients pay out of pocket. You may see something back on the Part B, the infusible side, with most favored nations, and you may well see something equivalent to most favored nation, because in the drug bill that was passed in the House, there was a provision that was very similar to President Trump's provision to basically base U.S. prices on international prices. Now, I want to say one thing about that. Drug prices are a problem. And not only are drug prices a problem because they're getting higher, but most importantly, what's a problem is what patients pay out of pocket. And the problem here is that in the United States, we see a growing gap between what is the list price, meaning think about it as a sticker price on a car when you walk in to a car showroom, that you're not going to pay, because you're going to pay what is the net price after you get a lot of discounts and things off of that price. There's a growing gap between list and net. When you look at these other countries, essentially their list and net are the same. The country may get a rebate back, but essentially what you see as that price includes that. So we're comparing apples and oranges when we look at this, because in this country, the reason why the net and the list price is diverging so much, or the list price up here and the net price up here, down here, is because there are all these mandatory rebates and discounts that middlemen and even hospitals take. So you have pharmacy benefit managers, which you've heard us talk about before, get these rebates because they go in the pharmaceutical companies and they say, if you want to get your drug used, you will give us a rebate. And so what happens is the drug gets priced higher because then a rebate comes off of that. The problem is that patients pay not off of the net price, they pay off of the higher list price. So what that means is that they are paying an artificially high price on any deductible or co-insurance or out-of-pocket funds that they have to put up to pay for the drug. In addition, you've heard us talk about before, hospitals get these 340B discounts. Here's the problem. The discounts don't go to the patient. They go to the hospital. And they go to the hospital to build big buildings, to pad CEO bonuses, to put to build extravagant lobbies with pianos in them, but they don't go directly to the patients. They don't have to. So as a result, they also fuel this gap between these list and net prices. So it's going to be very interesting to see how the Biden administration and this new Congress, controlled by the Democrats totally now, tackle the idea of drug pricing. The other thing that's going to be interesting is what the president does. Now, no offense to the past two presidents, Trump and Obama, but they didn't have the same passion for cancer that incoming President Joe Biden has. Obviously, his son Beau died of cancer. He has a history. He started the cancer moonshot. And so it's going to be interesting to see that any policy change that adversely impacts cancer patients, which we've seen before, or their providers in terms of allowing or providing basically accessible, affordable cancer care in their own communities, it's going to be very interesting to see how this president reacts either to the policies that he wants and what he does by executive action, or what the Congress does here as well too. But you're going to see at some point in time a full-out assault on drug pricing. The other little wrinkle here is, who is the incoming President Biden most dependent on right now? The pharmaceutical companies. Why? Because he's dependent on Pfizer and Moderna and J&J and AZ. I can go right down the list of all these companies that have vaccines, or these companies, Gilead, that has, an antiviral, and you want as many vaccines and antivirals out there as possible. So it's one thing to have Bernie Sanders or AOC wanting to obliterate the pharmaceutical industry. It's another thing when you're dependent on it. So I'm not telling you exactly how this will go, but I'm looking into the crystal ball and saying these are all the factors that come up. But make no mistake about it, you are going to see heavy emphasis on drug pricing legislation. I can tell you in terms of COA and our priorities, we've spent a lot of time in December with our government and government and policy committee, basically looking at government affairs and policy committee, GAP, we call it for short, looking at the strategy. And I can tell you that one of the top areas that we are going to go after are basically all of these middlemen and also the hospitals that get these rebates and discounts. We're going to go very aggressively after the PBMs, and the way these PBMs get in the way of dictating care. You may not know it, but most of the big insurers have a PBM arm. Most of the big PBMs are tied to an insurer. So as a result, the insurers want to tell you, the patient, what you're going to get in terms of care, not what your doctor thinks is best. And then the PBM arm is how to deliver it. If it's an oral drug via their mail service. And we see horror stories all the time. We are going to stop the PBM horror stories. We are going to insert PBMs into the discussion on drug pricing with the Biden administration and the new Congress. The other thing is, I can tell you right now, people say, oh, you're shelling for the pharmaceutical industry and you want to do away with the 340B discount program. Wrong. You heard it right here. we want the discounts to go to the patient instead of going to the hospital, or not even going to a community clinic, but going to the patient. When a patient in need, they should get the discount. It was a horror story the other day, reading in the New York Times, that the big conglomerate health system on Long Island, Northwell, which has LIJ, Long Island Jewish, other big hospital systems, basically was going after debt in the middle of COVID-19, this pandemic, aggressively going after patients for their debts. That's bad enough. But when you add on top of that, that they make millions and millions of dollars, and many millions of dollars, probably hundreds of millions of dollars on 340B discounts that go into the system, those discounts should be going to those patients. They shouldn't be going after those patients. So we are going to advance legislation. We're going to advance every attempt to have 340B discounts go to patients in need, not to basically institutions. So that is a big top priority of ours. Right now, I can tell you on a very short-term basis, and hopefully it'll be short-term, one of our priorities is getting all of our practices and clinics supply a vaccine to basically administer the vaccine. This is, as I said, it's just been a disaster. And if you think about it, cancer patients, whether they are 65 and older, or Medicare age, or younger, are the most high risk and immunocompromised. So highest risk to basically contract COVID-19 and have serious side effects afterwards, end up in the hospital, and and even worse. So we are looking the practices. We are communicating with 50 of the governors out there, the state governors, to get practices that have the storage, the freezer facilities, administer vaccines on a regular basis, to get these vaccines administered, because every oncologist accounts for, I don't even know the numbers, think about it, but could be literally hundreds of patients who are at high risk here, as opposed to sending patients out willy-nilly to go to CVS or anywhere else to try to find the vaccine. So that's on a short-term basis. So I think, longer term here with COA, PBMs and the insurers stopping abusive policies that get in the way of cancer patients getting their optimal, what they should be getting in terms of optimal treatment, and getting it right there at the clinic, as opposed to having to wait for it and call the insurer 58 times. And these 340B discounts and a number of other things that positively impact. We are working on what we refer to as payment reform in cancer care. And we want to say that providers, oncologists, should get paid based on the value of their services. Likewise, on the drug side, the drug company should get paid on the value of the drugs. So we are working on what we refer to as value-based payments. And that's one of the ways we think, along with instilling competition, is a way of bringing down drug prices. So let me stop there. Certainly Rose can answer any questions that you have or have come up in the chat room or anything like that, or I'll hand it back to you.
Yeah, Ted, thank you so much. It's interesting. So you talked a lot about the PBMs, pharmacy benefit managers, and just a reminder to everybody that we do have a compilation of what we call horror stories. So that's a horror story, but then you just told us about the other horror story about the hospitals trying to collect from patients during a really terrible time. So that's horrible on its own. But then there was the very uplifting story of the community oncologist who excused debt. Can you tell us, do you remember that story, Ted?
Yeah, it's just a great story. I mean, it was really, the juxtaposition was amazing. The New York Times wrote this story about Northwell doing debt collecting. And then you have an oncologist who unfortunately had to close his business doing his practice for staffing issues and all that, in Arkansas, which is sad enough because you lose another clinic site, but he forgave personally $650,000 versus debts. He wrote a beautiful card out to his patients, whether they owed $5, $100, $1,000, and he forgave all those debts. And that really shows you the difference between community oncology, independent physician-driven community oncology, versus conglomerate corporate-driven health systems that tend to be so impersonal. And by the way, the Northwell experience, it breaks my heart that, because I love the University of Virginia, but the University of Virginia medical system has been documented going after patients. Methodist health system down in Tennessee. I can go on and on and on and on. But it was a great story, Rose, having an individual
Yeah.
oncologist forgive those debts again during a very trying time and a pandemic.
Yeah, and I think it's really symbolic about what we try to do with COAs. You know, we do bring you the facts. If you go back and listen to any of these advocacy chats, we're very direct, we're very transparent, but we do deliver the hard news too. But we also bring you this uplifting news, and basically the way we're going to change things going forward is all of our efforts. You know, COA's membership is pharmacists, oncologists, nurses. It's the receptionists at the front office, and we're all in this together, and we're just going to keep learning together. And a reminder that not only do we have information on our website, we have really great content, little short YouTube videos. So basically, as much as you want to learn, we have it out there for you. And again, thank you so much, Ted. And you never have to apologize about being wonky, because we do always, at least I always introduce you as a policy expert. So thank you so much. And next month, if we can go to the next slide, Drew, please. Thank you. And I also want to thank our comms team behind the scenes. Next month is Cancer Prevention Month, National Cancer Prevention Month. And of course, many of us are on this call because we're either patients or survivors, or we work in the community oncology setting. But just a reminder, one of our taglines with CPAN is, we support the cure. All of us want to see cancer in the past. Cancer is a horrible thing to go through. No matter how many great stories we do have of survivorship, it's still really tough. So we do support the cure, but we advocate for the care. So we have a wonderful guest, Bo Eldegé, who's the founder and CEO of the Prevent Cancer Foundation. And then also, we'll save this for another time. Maybe we'll bring Ted back, or some of our other doctors. We're very concerned about screening and how screening has really declined during COVID. So you can learn more about that on our website. Thank you to all of our participants. Happy New Year again, and thank you for being with us today.